is the Chief Strategy Officer for Immunize.org, formerly known as the Immunization Action Coalition. The Immunize.org is the nation's leading developer and provider of novel and impactful immunization resources to advocate for and educate and facilitate immunizations. LJ holds a PhD in medical science, specializing in medical and public health policy development and advocacy pertaining to infectious diseases, with a particular focus on vaccine-preventable diseases, emerging infections, and antimicrobial resistance. Nationally recognized for his leadership in adult immunization and for leading the National Adult Immunization and Influenza Summit for many years, and for public health advocacy by organizing and mediating innovative forums to address important public health policy needs. He has been a longtime friend to the CIC, speaking at several annual conferences and webinars, and we're so pleased that he could be here with us today to provide a national perspective. So, LJ, please.
So thank you very much, Dr. Panaraj, for the opportunity. I just want to make a sound check. Can you all hear me?
Perfect.
Perfect. That's even better. I'm not even going to check if you can see me, because you know what? Seeing me is less important. So welcome, everybody, and thank you for this opportunity. I know the topic that's on your agenda is this what's next for public health, the future, and in immunizations. And I think the answer to that, as you've already heard Dr. Schechter kind of suggest with the budget in the White House budget, is there is going to be, because of all the things we've learned from COVID-19, a strong renewed focus on adult immunizations. And so I'm going to focus a lot of today's presentation on adult immunizations and some of the challenges that we have in front of us with adult and adolescent, a little bit too, vaccinations. And then I'm also going to just kind of get a little bit on my bully pulpit and talk about, what's next for public health. And I'm going to try to find some points to kind of bring that in, because I think we need to kind of reinvent the way we look at prevention. Obviously, immunizations is a big part of it, but not just the immunization component of prevention, but also the preventive health component and all the other things that we need to look at for public health. So that's kind of what I'm going to try to talk a little bit about, some disclosures, and then more importantly, a disclaimer. This is entirely my personal position or opinion. It does not necessarily represent official positions of Immunize.org or of the summit that Dr. Panaraj mentioned, because obviously I co-chaired that with the CDC and the Office of Infectious Disease Policy at HHS, and we don't want that to be the presumption is that what I say belongs to them. So a quick outline of what I'm going to talk about. And then I'm going to basically, a lot of this has been covered by Dr. Schechter, so at least for California and some national data as well. So I'm not going to spend too much time on that first component, but to basically kind of move into the second component with the call to action that was released by the summit late last year, talk about some strategies, and then talk about what's in the future for immunizations and public health. But before we do that, Catherine gave me the opportunity and asked me to kind of talk very quickly about Immunization Action Coalition. As we know, the public health workforce, continues to turn over, and I think it's an opportunity to again remind everybody that the Immunization Action Coalition, which has been around for 30 years, is now officially immunize.org. But what does that mean in terms of the rebranding? I think what it essentially does is we hope to reemphasize us as the premier source for immunization education and advocacy in support of frontline healthcare professionals. So that's our target, the frontline healthcare professionals. And all the work we do, either with education or advocacy in the background, is to support that frontline healthcare professional. And obviously, immunize.org is our website. So we are hoping that by harnessing that name, it is the most familiar name to all of you all healthcare professionals out there. And then finally, it reaffirms our mission to work alongside all our public health, nonprofit advocacy, healthcare, as well as pharmaceutical industry partners to provide free access to comprehensive vaccination education resources, and also to advocate for policies that will better protect the public from all vaccine-preventable diseases. Just to mention our three work pillars, we have three work pillars at immunize.org. Education and outreach to healthcare professionals, as kind of we suggested now. Advocacy at international, national, and state level to ensure access to vaccinations. And then finally, we also actively support the National Network of Immunization Coalitions, and obviously the California Immunization Coalition, thanks to Catherine and Cameron and others, are a big component of that coalition network too, and the role of the coalitions to improve the blanket of protection that vaccines can offer their community. A quick, hopefully you all get the slide. This is some of the resources that we have available to help facilitate all the work that you all are doing on the ground. I'm not going to go into too much more detail, except to just let you know that that's there. A lot more. So we've got a lot of resources available. And then I'm going to go ahead and now kind of start talking a little bit about the adult immunization component of where we're going with vaccines and public health. So I think, it's already been shown by Dr. Schechter, so I'm not going to go into a lot of detail. This is the United States data, similar to what he has shown. A couple of things just to remind people that, if you take a look at vaccination coverage rates, we have successfully administered, more than 589 million doses of COVID-19 vaccines across the US. You can see on the left-hand side, the breakdown by vaccine type, and then you can see on the right-hand side, the coverage rates among the various states. And more importantly, what I want to point out is that of those 18 and older, 76% have received 2 full doses. At the 65 and older age group, 91% are fully vaccinated, and that again is 2 doses. Recognizing that we do fall short when we come to the 3rd and booster dose, and obviously 4th doses for the 65 and older. The other place where we are falling short is among people in dialysis, where they're only 74% fully vaccinated. And I use that as an indicator of chronic illness and that fact that we continue to not do very well in general with adult vaccines with those who are chronically ill. But I want to take this and congratulate all of you all, because we can get adults vaccinated. This is what COVID has shown us, is that we indeed actually can get adults vaccinated. And we can see the impact of that vaccination. And this again is building on some of Dr. Schechter's data that he showed you in California. And this is now national data. The orange line that you see going up, that's the total number of cases per 100,000. So that reflects the number of infections that we continue to get in the United States. And then on the red bar shows you deaths. And I think what is important to look at is at the very final end there, how the deaths continue to decline, and even as our infection rates continue to go. And I think this shows us that obviously, as what has already been seen, vaccination against COVID-19 does indeed prevent deaths, prevent hospitalizations, prevent serious illness, even if it doesn't completely prevent infection. And I think that's something we want to keep in mind, not just for COVID-19, but for in general, the messaging with flu vaccinations and other adult vaccines, right? When you're vaccinating adults, it's not like pediatrics. That immune system is not revving up like a child's immune system is. And so as a result, adults, for us to expect the 95, 99% type of effectiveness against incidence of disease that we see in pediatrics is kind of foolhardy. We're not going to get those kind of rates for the adults. So what we want to make sure is we recognize that the effectiveness does indeed still remain with preventing severe illness, preventing hospitalizations, and preventing deaths. And because of COVID-19, there are a lot of things that we have now learned and developed as a result of it that will actually benefit our routine adult immunization efforts as we go forward. So obviously things like infrastructure improvements, and as many of you have already seen, the expanded use of immunization information systems across the United States for tracking COVID-19 vaccinations can obviously now be utilized for routine adult immunizations as well. Many new or expanding partnerships, and this is the big one, the expanding partnerships that were not focused on previously have now become established because of the COVID-19 pandemic in areas of equity, right? Using area agencies on aging and disability-focused organizations, the HUD-HRSA collaborations for persons in HUD-supported housing, rural health association work. So a lot of new partnerships that we can continue to hopefully sustain and leverage against routine adult vaccine-preventable diseases. And as a result of COVID-19, we also became more aware of some of the barriers. These barriers we were already facing, but COVID-19 just put a light bulb on it and said, look, this is our challenge. People with disabilities, equity remains a challenge. Rural areas, homebound, and there are other disproportionately impacted populations that COVID-19 exposed to us. But we can now take a look at this and see how we can use it for adult immunizations and leverage that experience to increase all vaccinations to all adults. So I'm not going to spend a lot of time here, but to remind you that because of the success that you all have done with pediatrics, the burden of vaccine preventable diseases is in adults. So here are just some numbers. I'm not going to read all of this out, but just to remind people, Streptococcus pneumoniae, if you take a look at pneumococcal pneumonia, 400,000 hospitalizations per year. Look at pertussis, 19,000 total reported cases in 2019. 4,400 of those were among adults that are 20 years of age and older. Hepatitis B, and thank goodness, just to remind everybody, you're going to see this after the break with the ACIP update. We have a routine recommendation, paradigm shift essentially for hepatitis B vaccination. Now, anyone 19 through 59 years of age is recommended for a hepatitis B vaccination series. So that's a huge paradigm shift for preventing hepatitis B. So again, something that we want to continue to push out there and implement on the ground. Zoster, 1 million cases a year with a lifetime risk of 32%. And I put measles in here because this is California, where we started today's conference with a Disneyland picture, right? But I want to remind everybody, if you look at your own data, 55% of those infections that happened in that multi-state outbreak that included 8 states and California, 55% of those infections were actually in adults 20 years of age and older. And yet that the impact in pediatrics was sufficient for your state to pass legislation that removed the philosophical exemption. So congratulations to you all. But again, notice that adults continue to be the poor stepchild to pediatric immunizations. And then if just to remind you all about flu, I think many of you know we have flu, and flu continues to be one of those big burden of diseases for all of us. This is data from the last 10 flu seasons from the CDC. And if you look at the pyramid on the right, deaths, hospitalizations, and obviously illnesses are a huge part of that burden for influenza. And a lot of that burden exists in the 65 and older population, as you can see on the left-hand side. Now, if the morbidity was not enough to convince you, if the mortality was not enough to convince you, I also want to show you some cost data with regards to the impact of adult vaccine-preventable diseases. So this chart basically summarizes a paper that looked at the cost burden of 4 adult vaccine-preventable diseases in people 65 years of age and older. And this was dating back to 2013. It was in the year of 2013. And essentially what was done was looking at census data, you could actually estimate the number of cases based on prevalence data from CDC of cases in 2013 for 65 and older. And then you can actually then estimate the cost as a result of those diseases. And as you can see, the bottom line is on the bottom right-hand side. In 65 and older in 2013, that's 1 year, these 4 vaccine-preventable diseases resulted in a burden of about $15.3 billion. Now, if you bring that age group down to 50 and older, you can add an additional $11.2 billion. Now, recognizing vaccine coverage isn't great, recognizing immunization effectiveness isn't 100%. Even if we just did better in either one of those, we're going to make a significant dent in the cost that we see for as a result of adult vaccine-preventable diseases, right? And clearly, you know, if you add COVID to this, you can see the immense impact we could have. So just to remind all of us again, that when we don't do well in general, the disparate groups tend to suffer. Groups that are of lower socioeconomic status, racial and ethnic minorities tend to become even more vulnerable to vaccine-preventable diseases when we do not do well in general. And I'm not going to run through a lot of these numbers, but you can see on the box on the right-hand side, these are the 2018 NHIS estimates. And as you can see, if you look at the vulnerable groups, a lot of people are missing vaccines, right? So you're looking at, for example, folks with hepatitis A liver disease, 16% coverage, for hepatitis A vaccination. Take a look at hepatitis B for 19 plus, 30%. Hepatitis B coverage in people with liver disease, 33%. Now remember, these are all ACIP recommended risk groups. So we know that. And the other thing we also know is that when you don't do well in general, racial and ethnic minorities, as you can see here, tend to also suffer. And this is the negative that's circled in red that I have here. You don't have to go through all of that, but all you have to do is just capture the number of minus negatives there are. And whenever there's a negative, this shows you a disparity from the white population in terms of coverage rates. So again, just a snapshot to show you that when we don't do well with routinely recommended vaccines for adults, we get disparities in terms of ethnic, racial, socioeconomic disparities, but we also get disparities in the chronically ill population. And because of this, the National Adult and Influenza Immunization Summit released a call to action in August of last year, right? And excuse me, just to also remind us, I apologize, that that not only were they low before the COVID-19 pandemic, these adult coverage rates, the pandemic impacted these already low adult vaccination coverage rates. So in other words, what we saw in pediatrics, we also saw in adolescents, we also saw in the adults. So let's not forget the adults here, right? So these extremely low coverage rates that we have coming into the pandemic were further exacerbated by the pandemic. And there was a lot of data that has been published to show that. And I'm going to just show you 4 resources that we've used and we've seen to show you that the pandemic has really impacted immunization coverage rates in adults, and as you see at the bottom as well, in children. So this creates a problem, right? Because this sustained drops has been measured in the following ways. And this is from an Avalia study where they basically looked and showed that claims for routinely recommended immunizations declined 26 to 46% across all the markets during the pandemic. Adolescents and adults experienced the greatest single drop in immunizations in April 2020 when we shut down. And then from January to November 2020, adolescents and adults may have missed over 26 million doses of recommended vaccines when compared to that same period just before the pandemic in 2019. And so this just shows you further up follow-up data that in general in 2020, the claims, while they continue to climb because of all the hard work that you all did, the claims continue to remain low and below the 2019 pre-pandemic levels. And this is data for adolescent vaccine claims. And what you can see here is you can see on the orange line, I hope it's showing up as orange for all of you, that's managed Medicaid adolescents. And then the blue line right below that, that's the commercial adolescents. And obviously you want to get up to that top bar of 0% when you are at the same level as pre-COVID. And as you can see, neither managed Medicaid nor commercial adolescent coverage rates, claims rates, which reflects coverage, get back to where we want to be. And obviously, as you can also see, as with the blue bars, when you can see that there is infection or new cases of COVID-19 disease, those rates begin to stagnate or they begin to flatten out because, again, people became a little bit more hesitant about going to see their providers and getting their coverage that they need to get. We see the same thing in adults. Of course, adults, we have a little bit more commercial plans up there. So just to show you some of those numbers, the red is Medicare fee-for-service, the orange is Medicare Advantage, the kind of blackish blue is the managed Medicaid for adults, and then the green is commercial payers. And as you can see, once again, before the pandemic, we were doing really well, and then all of a sudden, boom, we dropped during the pandemic, and we never really get back to where we wanted to be. And as a result, to summarize all of that, I'm actually going to skip this in the interest of time. That was flu specific. That was very specific to influenza. But as to summarize all of that, what we see in adolescents from the result of the pandemic is a loss in 8.8 million doses in adolescents and a loss in 17.2 million doses in adults. And so this requires recovery, right? We need to get back to where we were, or actually, if you think about it, we have to do better than what we were doing before the pandemic, because we have to not only cover all the routine adult and pediatric vaccines, we have to catch them all up as well. So we actually have to do better. And so let's take a look at how we've been recovering. And what we've noticed, that has been pointed out in the earlier presentations, is that the recovery from the pandemic lows is still not there. And that is true even in pediatrics, where so many dedicated providers have been trying to get our children caught back up. And this is data that you all have seen before. The first one is that kindergartner coverage rate data, which is about 1 percentage point below the target of 95%. Realizing that while 1% doesn't sound like a lot, 1% in a national population of kindergartners allows for the establishment of pockets that will actually result in outbreaks. So obviously a lot of concern with that drop. And but I think it is important to remember that while our administration of routine childhood vaccines returned to the pre-pandemic levels in 10 US jurisdictions, I think it's important to note that this rebound, as I've pointed out, only catches up those routine vaccines that are due as people come in. It was not enough to catch up all the people that we lost, that we did not give vaccines to and are therefore behind. And so back a little bit to adults, just to remind all of us, the majority of US adults are missing at least one recommended vaccine. And so this next data basically shows you some of the routinely recommended vaccines for adults, and basically to show you that there are substantial disparities in coverage rates by race, ethnicity, income, socioeconomic status, and that at least 3 out of every 4 adults are not up to date on just these 4 routinely recommended adult vaccines. And now obviously we have the big 5, it's not 4 anymore. We can add hepatitis B to that and relook at that data. And I can tell you that I think it will enhance our statement that routinely recommended vaccines for adults are not adequately provided for. So because of all of this, the National Adult and Influenza Immunization Summit, and you can see the link to this call to action, published this call to action back in August of 2021. And this is the web page that captures this call to action. And as you can see, there are many organizations, I think there are over 40 now, that support this call to action, and we list them on the right-hand side. And as you can see, these are just the A's, but from the A's alone, you can see we have some very wonderful partners that have supported this organization, including the American Medical Association, the American Medical Group Association, also better known as AMGA, the American College of Physicians, and going down to family physicians, we've got the pharmacists, and they're all organizations that are supporting this call to action. And essentially, this call to action reminds all of us that adults are missing routine vaccinations, and importantly, tells us that we need to follow the published NVAC standards for adult immunization practice in order to make up these routine vaccinations and to catch up all the vaccines that have been missed because of the pandemic. We are delighted at the summit that CDC, supported this call to action and took the call to action essentially and dropped it onto their letterhead and sent that out as well to their partners. And you can see that on the left-hand side. And what I pulled out is that little box in the middle there that talks about the adult standards for the standards for adult immunization practice. And just to remind all of us what these standards are, these standards essentially say that if you are a provider that takes care of an adult patient, right? Any provider, any adult patient, you are supposed to assess the vaccination status of those patients at all clinical encounters. You're supposed to identify the vaccines that these patients need and recommend them. You're supposed to offer them if you can. But if you cannot offer the vaccine because of reasons such as stocking of the vaccine or so on and so forth, it is actually on the provider to refer those patients to another provider who will give that vaccine, be it a pharmacist or some other access point. Then it is still important to check that the vaccines that have been given and received by your patient are actually documented in the IIS. And then if you are a provider, measuring your level of vaccination coverage rates provides a strong incentive to do better. And so the standards also advise that you measure the vaccination rates of through your patient panels as well. All that being said, right, this is a call to action. It tells you using the standards of care to measure yourself and to go ahead and assess and recommend. But at the same time, I think it's important to recognize that there's a lot of concrete steps that can be taken to improve adult immunization uptake, right? So many of us know this, and I think it is important to kind of remember that this exists out there, and this exists through the community guide. I show you the link out there. Many of you are aware that this is out there, but to remind us that there are 3 strategies for improving adults and promoting adult immunizations. You want to enhance access to vaccine services. I think COVID-19 has really capsulated that in a nutshell. I mean, we've got to enhance access to vaccination services. And I remind all of us that if we had been doing adult immunizations well before COVID-19 hit us, we would have not struggled so immensely to get and provide access to COVID-19 vaccines. And I think that's something we want to kind of remind ourselves as we come out of the pandemic, that we do not want to lose what we have built as a result of that pandemic and continue to maintain access to vaccination service for all our adults throughout the United States. As I like to always say, pandemic preparedness is because of everyday readiness. So everyday readiness translates into pandemic preparedness. And so the other two other categories, increasing community demand for vaccinations. Again, COVID has given us a lot of lessons on this, right? How do we reach targeted populations that might be a little bit more difficult with regards to getting them vaccinated, right? So we have learned about barbershops using trusted leaders in communities and realizing very much like politics, public health is indeed local. And then obviously provider and system-based interventions that many of us know already, things like the standing orders, electronic reminder recalls, and so on and so forth. And so just a little more detail. Again, this is from the community guide. These are some examples of how you can attack these different pillars. In terms of enhancing access, using innovative access points such as mass immunization clinics and eliminating out-of-pocket costs. So reminding ourselves that the Affordable Care Act says that all ACIP routinely recommended vaccines are to be covered without out-of-pocket costs to the patient. And as Dr. Schechter has already told us, if the president budgets gets through, there will be that vaccine for uninsured adults portion as well. In terms of community demand for vaccines, patient reminder recalls, family incentives to get vaccinated. And then, of course, leveraging that healthcare provider. Concise, consistent, confident recommendations are so important. And again, reminding all of ourselves as we come out of the pandemic that presumptive recommendations work, right? So remembering all the work we did with HPV, moving that all into adult immunizations and using that presumptive recommendation. And then finally, something I put here that's not in the Community Preventive Services Task Force guide, but to remind ourselves is that with the transition of healthcare delivery from volume to value, we need to engage our healthcare systems. And we need to promote those systems-based changes, like provider reminder recalls, assessment and feedback through the system itself, standing orders implemented through the healthcare system, and obviously leveraging all the advances we have in the IIS, bidirectional data exchange, health IT in general, so that the healthcare system is now a supportive network for access, documentation, and provision of vaccines to adults. So something to just kind of keep in mind. I'm not going to spend too much time on this next one. This is just a summary of a lot of the interventions that have been shown to work in adults. You can look at that in your own time. But I want to then go to this next slide and remind you that there are resources out there from the CDC to help assess for your vaccine needs for your adults, because it has to start with assessment. That's what those standards for care say, right? You got to assess, because if you don't assess your patient, if you choose not to assess your patient, you cannot deliver a recommendation for vaccination. So that assessment point is very important. Just to point out, there are CDC tools to help you assess your patients. I also want to point out that immunize.org has resources for innovative vaccine delivery and access points, including mass vaccination clinics. Just to show you the link to that resource. This is a site that allows you to basically look at all the best practices that have been done to improve vaccine access as a result of COVID-19. And hopefully we can use some of these resources, some of these best practices to develop unique access points for people to get adult vaccines. So now I'm going to switch just a little bit and begin to wrap up and show you where are we going with the future of immunizations? Well, clearly, we learned a lot from the research and development from COVID-19 vaccines, right? I mean, wow, what has been accomplished is amazing. Kudos to all the people that have been involved in the development of these in these COVID-19 vaccines. And clearly, obviously, the next step now is how do we harness all of this for future vaccines? And of course, you're going, LJ, this is happening, right? Definitely. So I'm not going to tell you it's not happening. It's definitely happening. And what I'm going to just show you is some of the future directions that are coming for both the mRNA technology as well as some of the other platforms that have emerged successfully because of the COVID-19 research and development for vaccination. So for mRNA vaccines, a reminder to all of us, it wasn't built from nothing, right? mRNA vaccine research and development has been going on for almost 3 decades. It's not new, right? It has been in a process and it was used to develop a vaccine against the original SARS and MERS viruses. Many of you may be aware of that, right? And then the other thing to remind ourselves as we talk about future directions for mRNA vaccines, we're all about jumping in and saying, can we do this? Can we do this? to remind ourselves that the spike protein is highly immunogenic, right? So this immunogenicity may not translate for all other diseases that we're going to try to develop mRNA vaccines for. So the target antigen in these other diseases may not be as immunogenic, so we may not have the same kind of success that we have with mRNA vaccines. But the great news is that we'll find out, because the ease and speed at which mRNA vaccines can be designed is very clear. I mean, we saw that with COVID-19. It is a huge step forward with vaccinology. And so it allows us to now try using the mRNA technology, the platform, in these potential vaccines. A universal flu vaccine, a pan-coronavirus vaccine, potentially protection against new SARS-CoV-2 variants, as we know. Dr. Schechter has already brought up the BA4 and 5. Potentially with RNA therapeutics and even in gene therapy. So a lot of potential for new directions for this. And specifically, here are some vaccine candidates that are in clinical trials against CMV, against RSV, against HIV, and against influenza. And then let's not forget some of the other platforms as well, right? So some of the other platforms are here. We've got the adenoviral platform against chikungunya. We have the VLP platform for malaria. We have the adenoviral platform against HIV. And of course, we have Novavax's and NIAID's VLP nanoparticle platform for influenza, right? And many of you know yesterday Novavax received their approval from the EAU from the FDA, VRBPAC, they received a recommendation from VRBPAC for the EUA. Obviously, FDA has to agree with that and issue the EUA, but that happened yesterday, just to let us all remember that. And so I'm going to stop here. I'm almost out of time, but just to now kind of talk about what is the big picture for the future, right? I think one of the things as we talk about immunizations, I think one of the things I want to remind all of us is that with adult immunizations and with immunizations in general, we have been focusing, especially because of COVID, away from this idea that vaccine effectiveness can only be measured by incidence of disease. So, when we hear the 94% vaccine effectiveness very, very early with mRNA vaccines against the original COVID strains, right? We're looking at that and we're going, wow, that's amazing. That's 94% against incidence of disease. That's really cool. But I think we want to remind ourselves that that is not going to persist. And as we've already learned, while the protection against incidence of disease declines, the protection against severe illness, against hospitalization, and of course, against death does not. And I think, or has not so far. And I think that's been true, and we've seen that for influenza as well. So I think one of the things we want to try to remember now is that our messaging for adult vaccines and vaccines in general should not just be focused on prevention of disease, but also prevention of these negative health impacts as a result of disease. And if we're shifting towards saying that, I think we then need to make sure that our societal expectations reflect that. So what do I mean by that? So let's think about that, for example, with my kid going to school. With COVID-19, if my kid develops a runny nose, right, we test him for COVID-19, and if he is positive, he stays home. Doesn't matter whether he's vaccinated or not, he stays home. What's interesting is that if he tests negative, what do many parents do? Well, before COVID, if your kid had a runny nose, you sent him into school. And I can tell you, if he tested negative for COVID, a lot of parents send that kid into school as well, simply because that's what the societal expectation is. That is something we need to change. We need to change our public health expectations to prevention in general, right? So it shouldn't be that my kid tests negative, therefore he's okay. My kid has a runny nose. He's not okay. He should stay home. It doesn't matter whether it's COVID positive or COVID negative. And I think that's the most important thing. It doesn't matter whether he's vaccinated or not. It should be on this emphasis of prevention. And I think that's where we need to begin to look at aligning our expectations for vaccination policy with our public health expectations. Another example for this, right? We tell our people that we want them vaccinated against COVID-19 because it's very important. And then what happens? We find out that there are breakthrough infections because of Omicron, because of these variants. And then we tell them we still need to test regardless of their vaccination status. And then we tell them that if they test positive, they can't do things. So we need to begin to adjust our expectations because this is a huge challenge for messaging for vaccinations. You know, how do I tell somebody to get vaccinated when they go for a vacation in Rome, for example? And then when they get on, we're about to get on a plane to come home to Rome, they still have to test regardless of vaccination status. And if they test positive, they have to stay in a hotel room in Rome. We need to figure out as a public health community, how do we align our expectations? So that being said, I'm going to leave you with that provocative thought because I know far bigger minds than mine are thinking about that. And I'm going to wrap up and just show you our summit resources and then thank all of you for your attention as I go off to kiss my pig.
Thank you so much, L.J. What a wonderful presentation. You could see in the chat, everyone, our audience thinks the same, that this was such a great presentation. We did have one comment that emphasized what you said, that it's crucial we recognize the failings of our public health system and need to continue to invest in public health infrastructure moving forward. Can you give us some specific advice on how do we do that?
Yeah, that's a really, really good question, right? So I think one of the things I'm going to say here, and again, this is not reflective of the people, my employer, because this could get controversial. I think public health has been very good at staying away from politics. All right, we've always said, you know what, public health should be independent. We don't need to worry about politics. But I think just as the way we say politics is local and public health is local, I think public health has to engage the politics. I think COVID has shown us that. We cannot stay neutral when we are worried about the politics of a situation. We have to engage as public health experts. We have to do that. And I think that means that we as public health people need to be ready to do that. You know, we need to learn how do you advocate and how do you engage policymakers. This is not something that we've learned or been taught how to do, and we need to begin to do that. I think at the national level, you're going to begin to see groups like Vaccinate Your Family becoming very, very engaged in this. I think it's because this is really, really important. I think we need to realize that we can no longer talk about politics, avoid talking about politics. One of the things, there was a great Harvard Chan Public Health roundtable of all the former CDC directors. And what really resonated to me along those lines is what I think it was Dr. Faggy. I think it was Dr. Faggy. And I apologize if anyone, if it wasn't, because I want to make sure I give credit, right? But someone said, you know, what's really funny is that at these budget discussions at the federal level, the Department of Defense comes in, they slam their fists on their table, and they say, we're protecting the country. We demand our $400 billion because without that, we cannot protect the country. And then the public health people come in and they go, can we just get $4 billion, please? And actually, if you can't give us $4 billion, we'll take 3. When we actually need to be slamming the table as well and saying, we're protecting the country. You know, look what COVID did, right? And I think that's where I think if I was going to say something controversial, I think this is what we need to do. We need to be able to bring these two topics together and show leadership in the politics of public health.
All right, thank you so much. We have so many more questions, but just in the interest of time and wanting to give the audience a break, we'll have to end there, but thank you.
I stay open. People want to email me directly. I love talking this stuff. So as Catherine knows, as Wendy, I see her, as you all know, just reach out to me. I'm happy to discuss.
Great, wonderful.
Thank you for the opportunity, everybody.
Thank you. We are going to take a 5-minute break, but when we come back, we have 3 breakout sessions. One is ACIP updates, pharmacy partnerships, and vaccine advocacy, access, and equity. And so after your 5-minute break, when you come back, you'll actually see on your left-hand side, there's a area called sessions, and then you can select the session that you want to be in and enter that session the same way that you've been doing for these other sessions. So it's very similar to being in an in-person conference where you have to leave the room and then come back. So hopefully that helps to explain it. So 5 minutes, Cameron, is at 10:19, that's what I'd have. Great. Okay, so we'll see you at 10:19.